Welcome to the Neuroendocrine Cancer Foundation podcast. I'm your host, Lisa Yen. I'm the Director of Programs and Outreach, as well as a caregiver and advocate for my husband who is living with neuroendocrine cancer. In each podcast episode, we talk to an expert who answers your top 10 questions. This podcast is for educational purposes only and does not constitute medical advice. Please discuss your questions and concerns with your physician. Welcome to the Neuroendocrine Cancer Foundation podcast. I'm really pleased to introduce our guest for today, Dr. Alex Phan. Dr. Phan is a hematologist and medical oncologist at the Froedtert and Medical College of Wisconsin. Clinical practice, clinical research, and education are the three pillars that are important to Dr. Phan's approach to cancer care. Her area of focus for clinical research and patient care are neuroendocrine tumors and malignancies of the gastrointestinal system. She has held several leadership positions, including Cancer Care Director, Founding Program Director for Hematology-Oncology Fellowship, Medical Director of Clinical Research, and National Director for the Gastrointestinal Cancer Program. She's been a popular guest on the Carcinoid Cancer Foundation's Luncheon with the Expert, where the audience has commented how much they really appreciate how she answers their question in an easy-to-understand way. Dr. Phan is clearly very knowledgeable, caring, and has a wonderful way of explaining challenging concepts in a way that's easier to understand and digest. And this is why we invited Dr. Phan to the Neuroendocrine Cancer podcast, specifically to demystify the topic of clinical trials, which can be challenging to understand. So Dr. Phan, welcome to the show. And I'd like to also share a fun fact that you just shared with us, that you used to skydive. So Dr. Phan, welcome. And you have to say a little bit more about skydiving.
Thank you so much for having me here. Yeah, that is a very interesting fact. And most people think I'm very mild-mannered and don't say a lot and very boring in my life. But I used to skydive. I actually got to the point where I was independently skydive. But maybe that's 5-10 years ago I did that. What got me interested is another person who's actually a neuroendocrine tumor patient who challenged me and said, "Oh my God, you're getting old. If I can skydive, you should learn how to skydive." So I was like, I can't let this challenge go without meeting it. So I did that, and it ends up being something I end up doing a lot more.
Wow, what a perfect example of how you can be inspired by your patients.
Yes.
And I think that's a perfect metaphor for cancer, not allowing fears to hold us back and doing something that may be even scarier and conquering our fears.
And if I can add that it's actually push and pull. Your care providers or your healthcare provider and the patients are partners in this journey, especially for neuroendocrine tumor. It is not a one person who tells you what to do, what's next. It's actually a partnership because it's a long journey. There will be a driver and a follower and vice versa. But most of the time, it's push and pull. You get feedback from your patient, and you're only a better provider if you listen to your patient.
That is really so meaningful to hear from you, how you view that relationship. And that's something that I know patients would like to have, that shared decision-making relationship. And actually, that's why we want to talk about clinical trials, because this is something that comes up often in the journey, and we don't know where it fits and how to have this conversation. So we really appreciate you coming to this podcast to explain a little bit more about that. But before we get into that, I'd like you to share with the audience, how did you get involved in neuroendocrine cancer?
So as another factor you don't know, I was one of the few participants that was at the first Nanette meeting a long time ago. But how I got interested in neuroendocrine tumor is this. I've always feel that any disease that doesn't have a lot of people getting involved, like physician or provider, or any disease that doesn't have a lot of treatment options, it is a challenge to me. It's almost like somebody telling me, no, you can't do this. There's no way you can do this. It's a challenge. So when I finished fellowship, I had two choices. I was in the GI medical oncology department. I had two choices, neuroendocrine tumor or upper GI gastroesophageal cancer. So gastroesophageal cancer is also another one that's very challenging. But I got interested in neuroendocrine tumor because the journey that you have or the interaction that you have with patient is a long-term relationship. Many of my patients I have for the duration of my career, 24 years. So I think that's how I got interested, in part by challenge and in part because of the unique relationship with patients.
I love how you're a challenge embracer and also that you really value those relationships. And we value that about you. Thanks for sharing that inspiring story. So let's start with the questions if you're ready for them.
I am.
Okay. So the very first question, let's go back to the basics. There may be a lot of confusion about what clinical trials are. So, what is a clinical trial?
So, to put it simply, clinical research or doing research in the clinical scenario involve many different things. There are qualitative research, there are various other things like population research, all of those things. But when we talk about clinical trial to patient, it is about interventional or therapeutic clinical research. For the most part, it's talking about an intervention or therapeutic research involving clinical protocol or what we call clinical trial. And these are research studies that involve human subject or human volunteer to evaluate the safety or efficacy of new investigational medical treatment, drugs, or devices. And they are an essential part of drug development or novel therapy in getting approval and getting made available to patients in general. So here are some key points about clinical trials. The purpose of a clinical trial is finding new ways to detect, prevent, diagnose, or treat disease. The phase of clinical trials are typically several phases because each of the therapeutic needs to go through these various phases to determine if they're useful or can replace standard of care. So phase 1 tests the safety and dosage of new therapy. They don't know what dosage work. They don't know what's the safety profile. That's phase 1. Phase 2 means that they have enough information about the dosage, what's safe, what dose should work. Now they're trying to assess efficacy. Is it working? And phase 3 is to assess whether that new drug is going to be able to replace standard of care. So they're usually randomized. And then phase 4 is post indications evaluation. Let's just say you got something approved and the drug is available. Everybody can use it for neuroendocrine tumor, but the sponsor or the drug company wants to know if this rare side effect, how truly frequent that is in the larger population. So they're following that with post follow-up. It's more like an observatory or observational study in documenting these rare events.
Thank you for defining what a clinical trial is and the 4 phases. So it sounds like there's 3 phases that lead up to approval and then 1 for observation for possible side effects after.
Yes.
Okay, thank you for that overview. So when in one's neuroendocrine cancer journey might a clinical trial be considered? Some people might think of clinical trials as a last resort. So when might it be considered and should it be considered?
Most people consider clinical trial, even us, we say clinical trials are evaluating novel therapies, hence investigational. So oftentimes people wait until the last resort. And then the other thing to consider is the fact that it's not easy for many patients to go on to a clinical trial. So that's why it's always left to the last resort when they don't have any other things to use to treat for their cancer or neuroendocrine tumor in this case. Then they will say, okay, now the risks justify me being more inconvenient, extending myself to find novel therapy. So there are many reasons why it's not considered as the first thing to look for. But clinical trials or therapies on a clinical trial should be evaluated every phase of your journey with neuroendocrine tumor. So when you first present and you have, let's just say, metastatic neuroendocrine tumor, you can then work with your oncologist or your neuroendocrine tumor provider and decide, okay, I know I have standard of care, but is there something better than standard of care that is being evaluated? So those are usually phase 3 study that you're evaluating when you first diagnose, when you have other standard of care option that's being evaluated. So there's many points in it, but I would say at the end of the day, a clinical trial should always be evaluated at every moment when you're looking at your scan and said, what's the option for me? It should be part of the option at every phase of your conversation about options.
Okay, so anytime, any phase. So you, as a neuroendocrine cancer expert, how do you consider clinical trials for your patient? Give us a little behind the scenes insight.
So I usually work with my patient in a very different way than I think many other provider. So I wouldn't be able to answer what other neuroendocrine tumor expert and how their process is. But I try to map out for my patient a couple of steps ahead of time instead of just what's next. Essentially, if patient comes to see me first, I would say, okay, this is what we're going to start first. And if this doesn't work, this is the next step, the next step. I try to reassure them that it's my job to be ahead of the game and not reacting to their condition. So I approach therapy or options or discussion of therapy and the recommendation for what to do next by trying to be ahead of the game and trying to look at the whole disease process and trying to line them up in a way that makes sense for the patient. That's my first approach. But there's really no standard way. So the way I look is this. If a patient has the mean and the feasibility to travel for clinical trial, and I know that there is some clinical trial or drug that I know is very, very promising, and they are eligible for it, then I would say that is the trial they should go for. Standard of care, as long as they don't overlap the mechanism of action, they can still be treatment option for that. Because if you go back in time, you have to remember this. Neuroendocrine tumor or well-differentiated neuroendocrine tumor, and it's important to distinguish this for patient. When you have an indolent disease like a well-differentiated neuroendocrine tumor, it's a long journey. It's a marathon. So you're ultimately going to reach every single one of those options that's out there. The key is to make sure that you don't lose those options by doing this or doing that. So you want to maximize the amount of option you have by selecting the option that's available in front of you at that moment.
That's a really important point, trying to maximize it all. And also knowing that everyone's going to get everything at some point. I think the question ends up being for a lot of patients, well, how do you make sure you're maximizing it?
So maximizing it means that whatever you're going to do is not going to burn the bridges for the next treatment. For example, if a patient already have low cell counts, let's say their bone marrow is not that great to begin with because they have bone metastasis. And so the first treatment I wouldn't recommend for them would be something that is going to suppress their bone marrow function even further, or burn that bone marrow function like radiation or PRT that can burn the bone marrow function and they can't recover to get the subsequent treatment. And then the other thing to think about is what are their symptoms at the moment that you can optimize? If they have no symptoms, you do not want to give a drug that gives them symptoms. That's the other thing. So if they have very little symptoms, they have disease that you know is not going to progress much more, they're very indolent, you don't want to give them cytotoxic chemotherapy that they're going to have nausea, vomiting, diarrhea. Their life is miserable. So the way you select things are several ways. You have to think a few steps ahead of their current situation. What is the next thing they're going to get? What is the next thing they're going to need? And what is the thing that they will be in trouble for? So these are things I think about. And I'm a little bit obsessive because I think about them all the time. If there's a patient that is complicated, I would probably think about them for days, even while I'm sleeping and dreaming, trying to like, what is the best thing for them? So it's these things over and over again. What is best for them? Are you going to improve their life and quality of life by giving them this treatment versus the other one? And then what is the next step they're going to do? Not just the next step, the next one. Is there a trial that is coming and you know it's coming and it's the best thing? So I don't want to give them something that will exclude them from that trial. So these are important things as I'm thinking about them.
Yeah, just hearing your thought process really highlights the value of seeing a neuroendocrine cancer expert because these are the things that you think about, thinking ahead, personalizing it for the person based on symptoms and not burning bridges. And these are nuances that not everyone can understand or know how to navigate. Sounds like a chess game.
Yes, it's a bit of a chess game, but this is where you need the feedback of the patient. For example, if I recommend PRT for somebody and they're like, can it wait until my daughter graduates from high school? Can I get something to bridge over until I get my daughter to graduate or go into college or something like that? Their life event, what they need in life is also very important in your decision making. That's why you need that personal relationship or therapeutic relationship, if you would, with your patient.
Yeah, so much of it is relationship dependent, which may be different from other cancers where there's a straightforward algorithm. And I think this is part of the challenge for someone living with this type of cancer, that it's not so straightforward and not everyone has the same treatments at the same time and the clear algorithm. So many people come to patient advocacy organizations and support groups wondering about the process of clinical trials. So what is the process of considering clinical trials? Would you be the one to suggest them or do your patients suggest them? And if your patients are interested, would you refer them to the clinical trial or is it their responsibility to reach out to the investigator if you're not the investigator of a trial?
The process of considering for clinical trial involves several steps. First, it's the initial discussion. Second, the evaluation of what's the best clinical trial. Third, it's information sharing. Fourth, it's referral. And then fifth and sixth probably is patient responsibility and ongoing support. So I think with the initial discussion, like I said, with my patient, at every single point in their discussion about what's the option now, this is where you sit down and you would present to them. And clinical trial is always part of that option. You're going to say you have these standard of care options, the pros and cons and the expected outcomes, and then these are the clinical trial that is ongoing. This open up a discussion not only of what you know in your institution and within your expertise of what's coming or what's there at the moment and what's available, as well as the patient. This is where they show up saying, oh, I heard my friend said that this drugs actually on a clinical trial is being evaluated. What do you think? So this is part of that conversation. This is the discussion that you have. Then the next step is the evaluation. Which one of those makes sense? Which one of those that they can travel to? Let's just say the trial that they discuss is all the way in Australia. Do they have the means to go to Australia to get that? And Australia has a lot of clinical trial with PRRT. So it's totally a place that is part of the conversation for clinical trials. But is it something they can do? Or is it just something that friend and family gave them and it's not even feasible? So first, that evaluation of which clinical trial makes sense at that moment. And if they pick that one, they're going to exclude themselves to the subsequent one. So that's part of the evaluation. What is the best so that you can prioritize, this is the trial for me. And the third one is information sharing. For example, if the clinical trial that's best for them is in my institution, I will then get them enrolled onto that trial. And usually if it's neuroendocrine tumor, I'm the PI, so that's not a problem. So it would be me. If I'm not the PI, let's say it's a phase 1 clinical trial, that is a very novel therapy, then I would then also refer them to my colleague to get that enrolled. Or sometimes I just get myself to be one of the co-PIs so then I can enroll my patient directly. I'm known to find different ways to get direct access, so then my patient have direct access. And then lastly, sometimes I have to refer them to places that they need to go to get that clinical trial. And sometimes that requires me putting the referral in and having the patient contact the clinical trial office for that particular one to get them to be seen. And behind the scene, there's a lot a provider can do. That is, give a personal recommendation or consult or curbside or heads up to the person that is the PI for that trial. That helps a lot in patient getting in. So that is information sharing for me and the referral. And the process of clinical trial, at the end of the day, it can't be driven only by the physician or the provider. It needs to be driven by the patient. So it's driven by the power of the patient and family, but it's actually guided by the provider, their physician. So that's the way I would look at that partnership in the process of a clinical trial.
Thank you for delineating that process of navigating this discussion. And what is the advantage of you being a PI or principal investigator or co-principal investigator?
So it's allowed me to enroll the patient a lot quicker than having me refer to somebody who then have to assess their disease, understand the disease, discuss the option of standard of care, which they may not know what is standard of care, and then get them on. It helps also because you're going to be following the patient. You understand about the drug that is investigated, but also you understand their background, what kind of things they run into trouble with. So then you can help them and say, okay, they're going to run into trouble with this. So instead of bringing them back for labs in 4 weeks, as the protocol indicated, I'm going to ask them to do some labs in 2 weeks so I know that they're not going to run into a problem. So these are kind of things I do that I think as a principal investigator or co-PI, you have direct access of helping your patient through the clinical research because you know their history.
Thanks for explaining that. So if I or my loved one is at a decision point and there's multiple treatment options available, including clinical trials, what advice or insights might you have to help make these decisions?
So I thought about this, and I thought about this long and hard because it's not easy describing clinical trials to patient. And nowadays there's a zillion different clinical trials, and many of the patients do not have the science background to understand that. So I tell them, you go and search wherever you want to go. Give me the list and I will tell you which one makes sense. That's one of the things. The key thing is the advice on decision making. This is my advice on decision making. First, which one is best for you before you even get there? Know what is feasible for you, the patient. So if you know that I can't live in the cold, well, don't find trial in Minnesota or Milwaukee. Or you're like, I need to have family around me when I go for treatment. So you need to find places that you have family because oftentimes for clinical trial, you may have to travel. It may not be at the same place that you've been getting treatment. So know what is feasible for you first. That's the question. Know thyself or what's feasible for you. Then the second thing is evaluate all feasible options. You collect the data, you partner with your provider, your neuroendocrine tumor expert provider, and see which one makes sense for you in your journey and which one that won't burn bridges for you for future clinical trials. That's the evaluation of those feasible options you have. And then the other thing is clinical trial suitability. For example, you know you can travel to Minnesota, but you can't be there every week to get therapy or get labs. So that is not something that is suitable for you. The other thing is that you know it is a clinical trial for you, but you have other patient's characteristic that is not going to be good for you. For example, if you have neuropathy, you don't want to be on a clinical trial that will make the neuropathy worse, or ototoxicity or hearing loss, that kind of thing. So which one is suitable for you? But you also have to know what is your standard of care option so then you can weigh in, okay, I have this standard of care option. I don't need to go to that clinical trial yet. Maybe in about 2 years, they'll become approved. So then I'll have that option. I don't have to be the volunteer for that trial to have that access. If my journey is going to be another 2 or 3 years, I don't need to go onto that clinical trial. I can wait for it to be approved. So understand the urgency of the need to get onto that clinical trial. And then the third thing to think about is the timing of the clinical trial. Where are they in their clinical trial? So for example, you have a drug that target a specific pathway that is very important in neuroendocrine tumor, but there's one company that is in phase 3 development, the other one is in phase 1 development. You don't want to go to the phase 1 because that means they're still trying to figure out the dosage that works, the side effect profile. Go to the one that's phase 3. So those are the timing to consider as well.
That's some key takeaways and some homework for us on the patient side, right? Knowing ourselves, knowing thyself, the urgency of treating, and then timing of clinical trials. So why it's so important to understand the phase and what phase the trial is in. I know you touched on this already and also earlier in the conversation, but when might a clinical trial be better than what's already available and considered standard of care?
I think this is difficult to say because it's hard for different patients in a lot of sense. And this is where you need that consultation with your neuroendocrine tumor provider. But there may be some situation where a clinical trial makes more sense. For example, if you don't have a lot of other standard of care except one standard of care left, you want to utilize your clinical trial at that time so that you can save your standard of care when you are maybe a little bit sicker, you want to be closer to home. So when you are not so sick, you can travel. That would be a good time to go on a clinical trial. And you want to save the standard of care when you need to be at home. So that would be one consideration. It's not the best or the sexiest, but it's a practical consideration when you think about all of your options that's available. The third thing that I think that a clinical trial would be best is that even though you have standard of care, but this one has been rumored among all the experts, it's going to be the one that is no toxicity. It's going to transform the paradigm of treatment for neuroendocrine tumor. You want to be on there. But at the same time, if they're so much closer to getting that approved, you might want to wait for that instead of go to get that on. So it's all about timing of where they are. If they're very promising, but that's going to be a couple years before you get to get the drug, well, you want to get onto that trial because you may need that now. But if it's so close to getting approved, well, then you don't need to travel to Australia. Well, I wouldn't say Australia or Milwaukee. You can wait for it to get approved. Yeah, who wants to be in the cold in Milwaukee?
Especially in the winter. That actually leads right into my next question. I was going to ask about timing. So you've talked about timing of the trial. What about timing of enrollment and how long does it take to start one on a clinical trial?
This is about understanding clinical trial process. The enrollment process is how they enroll you onto a clinical trial. It has become a little bit more complicated because pharmaceutical company or the sponsor who provide the drug for you or who is writing up the clinical trial has become a little bit more rigid and more specific. There is a pre-screening period, a screening period, enrollment period, and actually on to the trial. So the pre-screening is just that you're consenting so they can get information, tissue for molecular markers that you have tested. So then they can determine if you are a candidate for the trial. And then there's a screening period. The screening period is over a window of probably 2 weeks. They want to make sure all your labs is intact, you're healthy, walkie, all of the eligibility and exclusion criteria are met. So then they can randomize you, enter you, and randomize you. Once they say that you met all the eligibility criteria, your screening is complete, then they would enroll you onto a clinical trial. That means they would enroll you onto that trial and determine if you're going to be on one arm or the other, or when you're going to get the drug and what dosage you're going to be getting. And then you actually have to come in and get started on the therapy. So there are various ways of the enrollment process. So you have to understand where you are. So when they said, I'm going to consent you for pre-screening, that doesn't mean you're on the trial. It just means that you just consent to get your information so that they can see if you can even be eligible. Then there's a screening period. And then, of course, additional ones. So the enrollment process is actually complicated, but just because you consent, you need to know what you're consenting for.
That's really helpful. I think oftentimes when we're thinking of the clinical trial, we're anxious and wanting to start the treatment and really understanding that there's a process involved and there's many, many steps to that process.
And I think this is important for patients to understand too, is that when they see somebody and they said, okay, we're going to get you started on this process so that we can get you onto the trial. Sometime for you, between the time that you can sign the pre-screening consent to the time that you actually get therapy, it could be 4 weeks. Do they have 4 weeks in their disease process to get onto it? So this is where being the NET tumor expert and being the PI of the trial helps you saying, no, they need to be on something else. 4 weeks is too long. That is part of the conversation. And for most patient that has neuroendocrine tumor that is well differentiated, the luxury of time is there. But for patient that has high-grade neuroendocrine carcinoma, the luxury of time is not there. You need the trial to be set up. You need to do some of the homework and some of the pre-screening while you're on first-line therapy so that you can get onto that trial when you need it.
That's really helpful to know that it can take up to 4 weeks and it doesn't happen overnight and magically. So be thinking ahead and doing that homework in advance, especially if you're someone who doesn't have the luxury of time. Well, what if the trial's not available at the institution I'm at?
So many times, trials are not available at the one institution. Even MD Anderson or Memorial Sloan or any of those large institutions, they have a lot of clinical trial going on, but there are things that may be so rare that it's not available at the institution. So then they may have to be referred to other sites that has those clinical trials. This is where I need the feedback from the patient. Can they travel? Do they have the means to travel and live there? Because those clinical trials require you to be there. And typically, phase 1 sometimes require you to be there and get lab tests a lot more frequent than a phase 3 or sometimes a phase 2.
So networking and working, you mentioned behind the scenes with collaborators and sharing that information. Well, what about patients? How do patients keep abreast of clinical trials and how can they also then better understand the trials?
So I've seen patients go through a research symposium like NANET, ASCO, GI ASCO. They're there to look because at the end of the day, they're also professional. They understand some of these too. But it's getting involved in patient advocacy or getting to know their patient advocacy group. That's where they get information. Professional organization like NANET also is a way to get to know about clinical research, what's out there. One of the things that NANET is doing is updating, highlights. This is what's going on. Your advocacy is fantastic in the sense that you have these experts come in and talking about these things. From the very original setting up of LA NET here, you have expert comes in and say, this is very promising. Think about this. It's coming in 4 months, coming in a year, all of those things. That is part of how patient can get involved. But the other things that I think patients sometimes don't do enough to be updated is ask. You have to ask questions. You can't just say, okay, what's next, doc? No, you have to ask, what else in there? So the time to do these things, the best time is always anytime you want to, but the best time is when you are sitting there with the doctor who is reviewing your scan and said, you are responding, you're not responding, or you have stable disease. This is a time that you're going to discuss, okay, I don't like stable disease. Is there anything else I can do? It's those questions that you have to be able to ask, and don't be afraid to ask, because many doctor wants to give you the answer, but you just need to be asked.
Thank you for giving permission to ask and also highlighting the importance and the value of patient advocacy organizations. I know that when I started off, when my husband was diagnosed, I had no idea that that's where information comes from. And especially with rare or less common cancers like neuroendocrine cancer, and the value of patient advocacy organizations to hear the latest and greatest and to hear from net experts such as yourself. So, one question that comes up quite often is, how long do clinical trials take? So, if I or my loved one starts on a clinical trial, how long can I expect to be on it?
The duration of you being on the clinical trial is based on, are you tolerating it and are you benefiting from it? So if you're not tolerating it and they have to keep dose reducing or they have to hold therapy, then you can't benefit from continuing because you have too much toxicity. And then if you're not benefiting, meaning that when you're on the treatment and when they do a scan to evaluate your response, you are progressing, then you are not going to benefit. You're not going to be on the trial anymore. So usually the bottom line of how long you're going to be on the trial is this. Are you benefiting? Are you tolerating this? But in general, if all of those are met, the duration of the trial is based on the phase, the question they're asking. So if the question they're asking is like in phase 1, what is the dose and side effect profile? Then the duration of that therapy may not be years or decades. It may be just a duration of 12 weeks or 12 months. For phase 3, where overall survival is followed, you may be on that trial for a longer duration of time. But at the end of the day, it's about how long you're going to benefit from it and whether you are tolerating on therapy.
Yeah. Tolerability and benefit, and then understanding the research question that's being asked. Thank you. How often do clinical trials open and close, and how often do the spots open and close?
When you're talking about spot, you're talking about research slot. So there are local clinical trials. That means trials that are started only in one institution. And then there's national trials. And then there's international trials. So when it's local, the only competitor is just local. But when it's national, you're competing for that slot nationally. And when it's international slot availability. Majority of industry now do not say to the sponsor, do not tell the institution, you have 5 slots. They cannot say that. It's come as you are, and the trial that's available, they'll tell you, you are screen positive, but we don't have a slot for you until 3 months, for example. Whatever it is, it's first come, first serve, essentially. And your question about how does slot becomes available and when is it become available? It's hard to say because it depends on the clinical trial. Sometimes the clinical trial, let's say a phase 1, even though the slot is available and they said they're actively accruing, they're only accruing for a specific cancer, for example. In phase 1, a new drug, they don't know which disease works best. But for some reason, they're starting to see a signal in neuroendocrine tumor. So the slot that is going to be available would be only in neuroendocrine tumor. So then you have slot, but then you have to compete depending on the trial. Is it national, international, or local?
So, understanding the scope of the trial as well is helpful. And I want to circle back to what you talked about at the beginning in terms of making sure we don't burn bridges. And I think this is often on the minds of patients and caregivers. How can I optimize options? And if I want to keep my options open as much as possible for future clinical trials, are there certain things that I can do or not do to make sure that I'm not burning bridges and that I can make as many options available to me as possible?
There are things that are immutable that you can't change, and there are things that you can change and optimize. Things that you cannot change so that you can be on the clinical trial is this: your own personal performance status. If your liver function is not working, your kidney function is not working, and you're debilitated, it's very hard to enroll onto clinical trial. As paradoxical as it is, the people that need it the most are the people that usually are weaker and in need of the trial. But the purpose of the clinical trial is to get drug evaluated so that it can be approved. So essentially, it benefits the clinical trial to not have sick patient on there. So these criteria, these factors, if you're not healthy and your organ function is not working, no matter what you do, even if you have the president calling to endorse you to get onto that trial, you cannot get onto that trial because you are not going to benefit from it because your organ is not working. So it's harder to get through that investigational therapy. There are things that are somewhat flexible or modifiable that you can do to improve your chance of getting onto a clinical trial or not burn your bridges is this. Those things are when you are about to start on a therapy, whichever one that your provider recommends, you're going to ask, if I get onto this therapy, this is part of the question. Am I going to be excluded from other trials? Is the mechanism of action going to be the same as the one on the clinical trial? If that is the case, then you're not going to be able to get onto the other trial. It's going to exclude you from that. It's just a matter of asking that question. If I'm going to do what you tell me to do, am I going to exclude myself from other trial? It takes that question to get the provider to start thinking one more step beyond the current treatment. So that's one thing that you can do. The other thing is if there's a clinical trial or an option that causes you to be sicker, if after that therapy, I'm going to be so sick, I can't get onto a clinical trial because being sick, your liver, kidney function, or what's not being affected by that drug, that means that you cannot get onto a clinical trial.
Some key questions to ask. If I do this, would this exclude me from this future clinical trial? And also, how will I feel after this that might exclude me? And then just really the importance of we ourselves taking care of ourselves. Like you're the cancer doctor, you're taking care of the tumor. And we need to also tend to the rest of ourselves to be doing all the things to be as well as possible.
Right.
This has been really insightful. This is really super helpful. And I want to end with this last question. What's on the horizon for neuroendocrine cancers that you're most optimistic about?
I think there are several things that I'm very optimistic about. For high-grade neuroendocrine carcinoma, the DLL3, which is the delta ligand 3, is the best target that's out there for high-grade neuroendocrine carcinoma. Because of that target, several modality of therapy that is coming out or being investigated in the format of CAR T therapy, in the format of immunotherapy with T-cell engager, bispecific, trispecific, all of those things. And then, of course, radiopharmaceutical therapy is also finding using the DLL3 in patients to deliver their radioactive material more specifically to those tumors. So DLL3 as a target for high-grade neuroendocrine tumor, and it's expressed in more than 80% of high-grade neuroendocrine carcinoma. Then the other thing is, I think we are starting to use more molecular predictor to match up therapy for patients with neuroendocrine tumor. And you find some very unique markers, because we haven't done it in the past, that you can use to target patient therapy. And I like to do this, and not because it came from, we have a study for it. We have a study that actually is called precision oncology. It's called iPredict. What we do is we take a patient tumor, and it's not just neuroendocrine tumor, but any kind of tumor. We profile them in terms of DNA profile, protein profile, and a few other profile. And then we kind of match what is the drugs that is going to target for these patients, not single targets. It's multiple targets. That's the unique part, is that you're not attacking one target, but you're attacking multiple. It is a clinical research study. It's no mean the standard of care, but it is an approach that is not only personalized in efficacy, but it's personalized on safety as well, because we monitor them, we titrate them based on their side effect profile. So I think it's unique enough. But the reason I gave that example is that we're starting to think more about precision oncology in management of neuroendocrine tumor.
This is really exciting. So big picture, I think that it's really hopeful and helpful to hear about new targets, especially for high grade, where it can be really challenging to treat and to feel like they get the short end of the stick and very few options. To hear about this new target that's promising with new treatments attached to it. And then the idea of personalized oncology and personalized medicine, we like to hear that. Not like hitting everyone with the same things that may not work, but something that's personalized to the individual.
Right.
Well, this has been really insightful, really helpful. We've really enjoyed this conversation and learning from you. And our hope is to shed some light and insight to this field of clinical trials, to demystify it a little bit. I know we didn't dive deep into any particular treatment or trial, but just this insight may help us as we're navigating any clinical trial, because those trials are come and go, but really to help understand the whole field so that then we can make better decisions together with our NET experts. Thank you so much for that.
Thank you for having me.
We really appreciate you, and thank you for all you do on behalf of the neuroendocrine cancer community.
Thank you.
Thanks for listening to the Neuroendocrine Cancer Foundation podcast. We want to thank our podcast supporters, Novartis, Ipsen, Exelixis, Curium, Tercera, ITM, Resolute, Interscience Institute, and Boehringer Ingelheim. For more information about neuroendocrine cancer, go to ncf.net. We depend on donations to bring you programs such as this podcast. Please consider making a donation at ncf.net/donate.